now.
Peter.
We are live now. You can start, sir.
Vishal. Hi everyone. I'm Hyun Harrison Kim. Actually, we will start SMISS IP webinar. Uh, Actually, the moderator Eve is still not joined. I will read this program. This time we have uh, 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 lecture title with extra-foraminal lumbar disc herniation with MS strategies, and we have a very great speakers. And now we will start first talk from Dr. Wenjian Wu. He will give a talk of the definition, instance, and unique challenges related to extra-foraminal disc herniation. Wenjian Wu, can you start now?
Okay.
नहीं 5 मिनट बैठिए ना. I'll take 20 minutes. Yeah, I'll give a call.
Okay. Thank you, Chairman. Thank you, Moderator. Good afternoon, my esteemed colleagues. And today, our topic and our theme for this meeting is the extraforaminal disc herniation. So, as a start and appetizer, I will make a brief introduction to the extraforaminal disc herniation. My topic today is definition, incidence, and unique challenges related to extraforaminal disc herniations. Let's start with the case. This is a 31 years old male patient complained with right thigh pain for more than 6 months, and the BS for leg pain is about 7. The straight leg raising test is negative, and the femoral stretch test is positive. There is no muscle weakness. And this is the sagittal view of MRI, or you can see there's some degeneration of the disc, and there is no obvious and severe disc herniation from the sagittal view. But if we look at the actual view, we can see that at the level of L34, there is a extraforaminal disc herniation at the right side. We performed a selective nerve root block for this patient, and the result is positive, and we to make our final diagnosis of extraforaminal at F34 for this patient. So for lumbar disc herniation, based on the location of the disc herniation, there are 4 types, including central, the paracentral, lateral foraminal, or even extraforaminal, among which the paracentral disc herniation is the most common and account for 70 to 80% of all lumbar disc herniation. For extraforaminal disc herniation is a disc herniation lateral to the intervertebral foramen. There are other types, including far lateral, extreme lateral disc herniation, but some authors use the far lateral disc herniation include foraminal and extraforaminal disc herniation. So I think extraforaminal disc herniation may be more precise. The incidence of extraforaminal disc herniation is not that high, and it only account for maybe about 1 to 12% of all lumbar disc herniation. The most frequent site is L4, 5, or 5, 6 levels. For L5S1 is much more rare. Unlike the paracentral disc herniation, which is compressed, the traversing nerve root, the extraforaminal disc herniation will cause the compression of exiting nerve root or dorsal root ganglion. which will cause the pain or burning sensation. And for extra foraminal disconation, there are some challenges, including the diagnosis or the treatment for the disconation. From the literature, we can find that about 1/3 of the extra foraminal disconation may be misdiagnosed. There are some reasons for misdiagnosis, including the patient's symptom is not very typical. Some patients only complain for hip or thigh pain without any radicular pain. And from the standard MRI scan, there may not be easily seen from the standard MRI. And also, if the doctors focus on the intracranial lesion, maybe the lesion can be more easily ignored. And if the patient, there is some age-related comorbidities, including, for example, lumbar canal stenosis. If we focus on the lumbar canal stenosis, the extra-foraminal disconation may be ignored, easily ignored too. So for some patients, maybe we need some special coronal extended actual MRI scan, or even 3D nerve root reconstruction to see more clearly for the extra foraminal disconation. And for highly suspected patients, maybe we can try the selective nerve root block to make our diagnosis. Of course, for all the disconation, even for the extra foraminal disconation, we can try the conservative treatment first, but sometimes it is not successful. We're very cautious that if the compression of the DRG, the duration is too long, it will cause the irreversible neurological damage. And even we perform the surgical decompression, the recovery will not so satisfactory. So during the conservative treatment, we should use some maybe something like EMG or series imaging just to monitor, to check the result of the conservative treatment. If it failed, we should not hesitate to perform the surgery. For the surgical treatment for disconation, interlaminar approach, use the loop or microscope or even a tube is the most common used approach. But if for the extra-foraminal disconation, if we choose the interlaminar approach, there are some problem. We have to, if we choose this approach, we have to remove the most or even all the facet joint, which will cause the post-operated instability and may need fusion. And on the other hand, with this approach, maybe we cannot see clearly and will cause the inadequate decompression and also the nerve root injury. So for extra foraminal disconation, maybe we can consider the posterior intertransverse approach with the microscope, or even we can try extra-foraminal endoscopic laminar discectomy, or even we can try contralateral discectomy with the UB technique. Or sometimes some doctors even use the lateral approach. But there are no, I have to say, there are no consensus about the optimal surgical approach for extra-foraminal disconation. And for a level at 5S1, the surgical treatment will be more challenged. There are two reasons. One is the position of the disconation is quite deep. The other hand is the working windows for these lesions for extra-foraminal L5S1 disconation may be obstructed by the big L5 transverse process and the airline and also the iliac crest will make the approach and make the surgery very difficult. No matter you use the microscope or endoscope. So I think that the following the speaker will maybe give us more detail about this the difficulty. And the other problem about the surgical treatment is that since the DRG, the dorsal root ganglion, is very sensitive, so even we do not direct the injury the DRG, but if we perform too much, we make too much traction and or even some thermal injury for DRG, the patient will feel intractable pain after surgery. And also there are some risk of the residual disc material and recurrent. So as a summary, for extraforaminal disconation is not so common type. It's not a common type of the dermal disconation, and we should very cautious that it is easily misdiagnosed. For surgical treatment, we should make an individualized surgical approach just to balance the exposure and nerve safety and to get the satisfactory result. Thank you very much.
Okay, thank you. Hi, I'm Raymond Yip. Sorry, I confused the date for tomorrow. I'm the moderator. So thank you for the excellent summary, Dr. Wu. I agree it's a difficult subject for the herniation, and the points that you've made are very valid about it being sometimes difficult to do the approach and being able to fully decompress these extraforaminal disc herniations. And because the dorsal root ganglion is very sensitive, these discs are usually very hard to treat, and they are quite frequently symptomatic. So do we have any other questions from the participants and audience? It's an excellent summary, and it summarizes so it's difficult to treat if you go posterior, trying to preserve the bony structure, the facet joint. Our approach is to try and preserve the anatomy, to try and remove these difficult disc herniations. If not, we'll go to the next speaker, which is Dr. Kim on monoportal endoscopy. So Dr. Harrison Kim, thank you.
Okay. Can you see my slide?
Yes.
Okay. Thank you, Chairman, Dr. Raymond. I'm Hyun Kim Harrison Kim from Harrison Pin Arthurs Hospital from South Korea. This time my lecture topic will be the uniportal endoscopy for extraforaminal lumbar disc herniation with MIS strategies. We know that some extraforaminal disc looks like very difficult before we have so many kind of operation and so many difficulties to get the excellent clinical surgical result. This is my curriculum vitae disclosure. Today my content. And in the endoscopic spine surgery, there's a more good approach to the deeper point, especially foraminal and extraforaminal area using the very small working channel. And there have three kind of the approach for foraminal to extraforaminal by the uniportal endoscope, by the from transforaminal approach and contralateral intraminal approach and the paraspinal approach you can see here. Here, contralateral intraminal, this posterolateral, this transforaminal approach. Yes, firstly, you can see here that this case is L5S1. I have a severe back pain and leg pain for a long time, but the MRI showed not so severe cases, but the patient complains so long time in severe pain. But if in spite of that, the L5 is on, that is not easy to operate to this point because of the many cases we try to some non-surgical treatments, but the patient still have some complaint because of that. If we get the good result using the endoscopic spine study, the patient will take a more good life, return to his life. To summarizing my clinical data of the last 1 year, we can see with the some applying the endoscopic spine surgery for all degenerative patients, there have so many cases of spinal decompression cases. You can see are about near more than 30 or 40% of cases. But you can see here another lumbar foramen also have a more than near 50% of patients that need some lumbar foramen, meaning that so many pathology of the foramen itself, foramen that they need the patient need a more minimized option of treatment. Firstly, we talking about the transforaminal approach, but in the we know that the endoscopic transforaminal approach is a very good surgical tools to foraminal to extraforaminal area. In the cases of foraminal to extraforaminal disc, only these cases we more easily to approach like using this mobile outside technique, but more easily approach to the target point, and sometimes we can move to more deeper point using the mobile outside in approach you can see here. Then we can, it looks like this case is also so severe, huge foraminal to external foraminal cases, easily to manage using the Monoportal Endoscopy spine in a transforaminal approach with some mobile approach technique. And also, this another cases you can see here the L1 to foreigner to superior migration cases also that actually this case is very difficult cases before, but using the endoscope so that we can more easily operate to this area and post-operative MRI showed good result. But some of the cases of the extraforaminal, these cases, especially L5S, has a so severe pain because of the insertion of working channel is not easy because using floating technique, firstly float the docking near to the disc area and firstly limb the disc because of that endoscopy is more clear. Checking the exiting the root and some another anatomy because of that. We firstly remove the disc, then insert to the target point and checking the finally the free nerve root. Then we can the patient take a more good results to like this way. And so, some another case like combination of the some spinal stenosis, osteopathic patient that can possibly easily some operate to the target point with some drilling of the bony osteopathic point. Then you can see possible another cases you can see similar cases also can see the uh, with some resection of the transverse and iliac area, then a lot area we can see up more easily up to the target point. Then after operation, we can see the pathology can be the sufficiently. But some of the cases are like a foreigner to superior migrant cases or foreigner to extraforeigner cases, not really transforeigner area in that case. And also in the cases that we operate from the transforeigner area, there sometimes need some traction of the dorsal to ganglion that Wenjian Wu talking that there is some danger to the nerve damage because of that in that situation you can operate from the contractile side you can see like this way, then more safely operate to the target point without damaging the area, then like this way. Then you can see, like this case is prior to superior migrant cases. L5 is the best difficult cases of the some extraterrestrial approach. In the cases, we can approach it from the contractor side, and then more safely limit this area. And another case is like this primary to paracentral foraminal extra-foraminal cases with disc and stenosis combined cases will also contractile and trauma cases have a good, excellent clinical result with the all component by the only one approach point. Then you can see these 2 year follow-up the patient take excellent clinical results. This case is also interesting cases of a combination of spinal stenosis with the foraminal extra-foraminal cases also firstly decompression of using the large scope, then change the small scope, then more easily approach to the target point than the this pathology safely removed from the contralateral internal approach area. Then the patient also can take excellent clinical result. But so many cases of the this pathology combined with the stenosis in this situation, I recommend paraspinal approach rather than the contralateral internal approach. Sorry, why the slide? Oh, okay. You can see here these cases also some stenosis with foraminal stenosis with disc herniation together. In this situation, some paraspinal approach like this way and exposing that area, then you can see the acute nerve root decompression to there. And finally, we see the free acute nerve root and then maybe the disc together. Then the patient can take the excellent result, can take it. Because of that, the endoscope you have a more clear view. We can more clearly to manage to this area. This another case is similar case show like this way. This another case is combined with the disc extraforaminal disc case also. Firstly, decompression of foraminal area, then remove the disc more safely, removal of disc without any the dorsal ganglia. This another case is also similar cases. Yes, you can see this case is looks like uh, mild stenosis with the disc, chronic disc cases. In this situation, using the post-structural SAP total resection decompression, the patient can take excellent clinical result. I believe that using the endoscope span surgery, we can more safely, more easily, more wide indicated alpha foraminal to extraforaminal disc pathology can make them more successfully. Thank you for your kind attention. Thank you for your kind attention. Raymond? Raymond? Yeah, my talk is finished. Do you have any question from the audience? Vishal?
Well, I can't see in the chat box any question so far. So maybe, yeah, my question to you, can I, Dr. Kim?
Can you ask to me?
Yeah, can we have questions from the audience? Sorry, my something wrong with my microphone. Can't get the screen back up. Yeah, okay. I think you can see me now. Do we have any questions? Okay, so I think the endoscopic approach is actually the perfect way to access these because I don't do that many endoscopies, but if I have an extraforaminal or foraminal disc herniation, I still do the endoscopic approach because it's the easiest way in there to remove a foraminal disc herniation, and you can clearly get a. Sorry, Arvind is calling me. We can easily access the foramen very easily from an endoscopic approach. So we'll proceed with endoscopy and talk about UBE. So we have Dr. Aygun talking about UBE. Sorry, I'll just mute this. Okay, Dr. Aygun, please.
Thank you.
And can we share the screen? We have the screen. Oh, hang on. Maybe he's not available. We'll proceed to the, I don't see him on the, okay, well, I think we'll just proceed to tubular then. So, Dr. Kundnani. Hi. Hi. Can we talk about tubular? And I'll see what's happened with Dr. Aygun. I don't know. He's maybe not available. I can't see him on the participants here. He's not online.
No problems. I'm all
Yeah,
set.
sorry if you proceed. I think Arvind was trying to call me to tell me that. I don't know.
No problems. Thanks, Raymond.
Okay,
I
thank
think
you.
far lateral disc herniation, my job has been made very easy by my previous speakers who have actually brought forward the anatomical and diagnostic challenges in management of these problems related to far lateral disc herniation. As we all understand and know that far lateral disc herniation is only one of the radiological variation as a diagnosis to presentation of radiculopathy, where the compressive pathological element of the disc is lying lateral to the facet joint line. And that's where we call it like a foraminal presence or extraforaminal presence. So it is the disc fragment is away from the conventional central or paracentral approach, and that's where the compressive disc fragment lies. And why is it distinct to mention it as a separate entity? Is because it is not amenable to conventional posterior approaches which help us in accessing the central or posterocentral disc herniations. And you actually require either have to resect the facet joint partially, totally, or you have to go from far lateral approach to directly reach this disc fragment. And it's very, very important to understand this pathological anatomy of this very individualistic anatomical variation of the disc herniation. Otherwise, you'll end up doing more without having achieved the target outcome. And we must understand that where to look for this fragment in a patient with a clean looking MRI, because patients are often very symptomatic. However, the MRIs are very clean, so-called apparently clean, because the fragment is not lying in the mid-sagittal area where the common eyes of the orthopedic or spine surgeon lies, but the fragment lies in the foramen. As you can see, the central part of the canal does not show any compression, even in a patient with very, very severe symptoms. So the fragment actually lies lateral to the facet joint line, and that's where the far lateral segment, and that's the very precise reason why these far lateral disc herniations often go undiagnosed or are misdiagnosed, and many a times mismanaged as well for the same reason. And that's why a very high index of suspicion by all orthopedic and spine surgeons is that the eyes should also look away from the conventional position of the disc herniation into the lateral zone or the far lateral zone, where you'll actually find these disc herniations lying there compressing the nerve element. This absence of the disc fragment in the conventional place is also one of the reasons that they are mismanaged, but also the inability of the conventional approach to reach the target fragment of far lateral has resulted into these fragments being persistently present despite a surgery done very well. You often either lead to a pars injury or you're not able to reach that fragment if you take a usual posterior midline conventional approach for these disc herniations. And that's the reason that these often go misdiagnosed or mismanaged in common hands. We must understand that the fragment lies lateral, and that's why the access path also is lateral, and it has been described very well in the past also by Wilson et al. That it requires a paramedian incision, paramedian access, paramedian muscular dissection, and intermuscular plane should be taken to reach that particular disc fragment. More often than not, this leads to challenges of muscle trauma and bleeding, as Wilson described in his approaches. And many a times, if you do a excessive pars resection to reach there, you may actually create iatrogenic instability. And these challenges of muscle dissection and collateral damage in Wilson approach led to the inception of a TLIF as an access path, which is the transforaminal lumbar interbody fusion for all these far lateral disc herniations. As my next speaker probably is going to speak about the option of TLIF in such patients. However, I personally feel that fusion is overkill in such patients just to access that area, when you have options like endoscopy and more so now a simpler option of tubular microendoscopic decompression. Now, microendoscopic tubular decompression surgeries for these far lateral disc herniations are extremely simple, and they are as simple as you do it for any other conventional paracentral or a central disc herniation, except that the docking point may change little. It only involves using the tubular portals under a microscopic vision, giving you 3D view and a depth perception, along with the use of same instruments, making it a very resource friendly and without additional learning curve involved into it. It results into a direct visualization of the nerve and the disc fragment without actually leading to collateral damage of the muscle, because you don't have to strip off the muscles. You actually go by dissecting within the muscle fibers, reaching directly on the target point of the pathology. And this is what overcomes the challenges of far lateral disc herniation, and its location can directly be accessed by these tubular portals there. And advantages are plenty. One cannot really neglect them, not only because of the direct visualization of the nerve disc and the pathological fragment, resulting into a minimal handling of the nerve root while doing a decompression discectomy, but it also adds on the versatility and the dynamicity to this particular procedure, making it extremely effective. Even if there is a associated lateral canal stenosis or a foraminal stenosis or a facet hypertrophy pinching on the nerve, you can actually take care of it then and there. And the best part is, it is not only easy, but it is also very resource friendly. You can use this common instruments that you use it in your conventional open surgery also, why these tubes are there. And it's a very forgiving surgery, because none of your patients actually, even if you develop dural leaks, are going to really get converted into fistulas. You don't have to add anything as a specific mention to this. Now, when it comes to tubular microendoscopic discectomies, one simple basic rule which is different from conventional surgeries or conventional open or conventional tubular surgeries, it is the docking point. Because the target fragment or the pathological fragment lies lateral to the facet joint. So your docking point of the tube also is slightly different. And the conventional spinolaminar junction, which is the docking point for paracentral and central disc herniation, it changes a few centimeters lateral and superior. And it is the pars transverse process junction. As you can see in the middle X-ray, that the needle gets docked on the pars transverse process junction. That needle is actually the docking point of your first dilator, followed by sequential dilators, followed by your tube, which gives you direct access to the nerve root and the disc fragment lying there. Yes, it gives you direct access to the nerve root, and to avoid nerve handling, you can actually wand your tube slightly inferiorly and go under the nerve root, getting the disc fragment, which often pushes the nerve more dorsally out there. So this is just pictorial representation of intraoperative C-arm pictures, how you get your dilator fixed on the pars and also the transverse process junction, and it can all be visualized under the C-arm, and you can easily get the dilators out there and the muscle that is coming in between. Even though you're lateral, it'll give you a wonderful dissection between the muscle fibers without actually bypassing the problems of muscle dissection and bleeding, which often is encountered in conventional techniques. And that's how your tube gets docked. As you can appreciate, the tube docking is away from the conventional spinolaminar junction, and it is the pars transverse process junction, as you can see on the extreme right side, which gives you a visualization of where your tube gets docked there. And that's how your tube docking looks like. It visualizes a part of the pars, which actually becomes the docking point and gives you a bony anatomy and the representation like a lighthouse when you get missed here and there. Now, the tubular docking can vary. There are some surgeons who say that docking directly on the nerve root may lead to a more handling of the nerve root, so you can actually wand it inferiorly. But directly docking on the facet joint or superior articular facet can lead to a capsule damage. So in my hands, I usually dock at the pars transverse process junction superiorly and then wand my tube inferiorly after I have docked the tube already there. This gives you direct access right on the nerve root and the disc fragment, which is right in front of your eyes. And actually, believe me, the surgery can get over within 20 minutes time. The moment you bring out the fragment, the nerve gets free. It, of course, throws away some epidural bleeding, but it is very accessible and amenable to your bipolar cauterization there. There's just one case example and a small video of 5 minutes, which will show us how we do these surgeries. As you can appreciate, that the disc fragment is on the right sided in the far lateral area, pinching on the nerve root, pushing the nerve root dorsally, and the fragment is lying just under the nerve root, pinching on the dorsal root ganglion, creating disproportionately high symptoms compared to the other ones. And to give you a orientation, the top portion is the medial side and the lower portion is the lateral side where the tube docking will happen. The right side of the screen is the capillard end, and the left side of the screen is the foot end, as you can see is mentioned there. So this is the case with patient coming with right-sided radiculopathy, severe pain, and this is the area where we have to go. That's where exactly the disc fragment lies. No instability noted on flexion extension. Now, what is peculiar to our scenarios? We do these surgeries as awake spine surgery. We have been using regional anesthesia, and all these patients are awake all the times. And because the surgery is a short timed duration surgery, we actually prefer doing it under awake spine surgery, and patients are awake all throughout the surgery. Intraoperatively, some markings are done to see where the incision is going to come. As mentioned, the incision is paracentral. It is not like 1 centimeter lateral to midline, but it is actually 3 to 4 centimeters lateral to midline where the incision comes. And this is how the needle gets docked. Once the needle gets docked on the pars transverse process junction, the only thing that we now have to do is to start docking with our dilators going there. That's the area where we are going to dock our tube. I use adrenaline soaked saline to create a dissection between the muscle planes. The first dilator of 6 millimeters, followed by dilators up to 19 millimeters. The depth here is 50 millimeters and 19 millimeter diameter tube mounted to the table mount to make it a fixed tube retractor. And that's just a pictorial depiction of where your tube gets docked. You confirm it intraoperatively with the C-arm imaging to see where your tube is getting docked in line with the disc fragment there. This is exactly the area where we are going to get docked, and we are going to see the pars right there. Of course, some amount of muscle tissue might have to be brought out, and the inferior side, you can appreciate the capsule there, which remains untouched, preventing the problems of adjacent segment. The cautery actually runs medially on the pars, and laterally it touches the transverse process of L4 and L5 both. And that's exactly where we are going to get landed up. The only thing that you have to do is few bites, maybe a 2 millimeter bite on the pars, and the ligamentum flavum underneath the pars will be the roof of the nerve root, which just requires a careful dissection, as you will see in the video. As you can appreciate, you use a burr and just 2 to 3 millimeters of pars dissection. In this case, there was associated foraminal stenosis, so we did a partial decompression on the inferior aspect to take care of the stenotic component also. The shiny surface is the yellow ligament. And using a diamond burr, you can actually go all the way. Inferiorly, the superior overhang of the facet is taken care of. The only one problem that all our tubular spine surgeons face here is the bleeding in the lateral zone. One has to be careful that over resection of this pars should be avoided. Otherwise, a iatrogenic pars injury can be created. And that's why your dissection and your resection should be limited only in the lateral aspect. And the inferior aspect of the transverse process should be your guide of how much bony resection is required. Remember, the nerve root and the dorsal root ganglion actually kisses the inferior aspect of pedicle and runs just inferior to the transverse process in this area. And that's why your forward ronger should be careful and should not dig in to create an injury to the dorsal root ganglion, resulting into post-operative paresthesia. The nerve hook is just an extension of your finger to dissect the ligamentum flavum on the top of, that's what is dissected. And the shiny surface of the nerve root will be seen the moment your ligamentum flavum is dissected. And just underneath the dorsal root ganglion lies your disc fragment, as you will see in minutes. As mentioned, bleeding in the most lateral aspect is trouble at times. And so I generally don't like to use patties in this area because they can actually irritate the dorsal root ganglion. And that's why a patty is only used in the traversing foramen where it pushes the dural sac away and gives you an area where the disc fragment lies. And this is when your nerve hook actually passes under the dorsal root ganglion to give you access to the disc fragment, which is very clearly coming to just glare at you and wanting to come out. These are adhesions there. That's the fragment which is pinching the nerve root, and it just walks out. Right from here, you can actually enter into the disc fragment, locate the annular defect, and do a intradiscal discectomy to take out any loose fragments in there. And this is like direct visualization of the nerve root, direct visualization of the end point of decompression. You can dissect under the axilla. You can actually put in your nerve hook in the traversing foramen also. If there is a paracentral component, can be very well taken care of. Like in this case, there was an inferior fragment going inferiorly migrated also, which was taken care by doing annulotomy. And the disc fragment from inside, loose fragments were also brought out. Just a cruciate extension of the annular tear which was there, and intradiscal loose fragments are removed. And the hallmark of tubular surgeries is that the moment your decompression is over, you are able to visualize the nerve roots right in front of you. And the moment you pull out the tube up, all the muscles just fall back, leaving behind no dead space, either for any hematoma or if there is an incidental durotomy to result into any pseudomeningocele formation or CSF fistula. The fascia is also so tight up there, you can actually just close it with a single stitch. And all this is awake. Patients can really walk the same evening. And most of these patients are comfortable enough. Their pain relief is so excellent. They walk and are ready for discharge either the same day or the next. And that's the nerve root. And the moment you bring out your tube, only 18 millimeter incision in such cases. And the advantages, as we just discussed, are plenty: direct decompression of the nerve root, removing all the fragments without actually need of too much handling of the nerve root, and can be taken care of even in cases with adjacent or same level LCS. This can be combined with the same incision, can be used to tackle the above or below levels if there are multiple levels of disc herniation. And if required, a fusion can be done. It's pretty simple for all those guys who are using tubular technique already. And it's very resource friendly because the instruments required to do these surgeries are same as your any other conventional open surgery or tubular spine surgery without the need of investment into this. Some case examples: a right-sided 43-year-old male right radiculoplateal L4-5, again managed by the same method using a 16 millimeter tube. Another case scenario in a 51-year-old female with a very, very obese patient. As you can see, the depth with the fat in posteriorly. Again, a 18 millimeter tube, a longer version, and patient was discharged the very same day. High level lumbar disc herniations also, like L3-4 in this patient with knee weakness, was managed very effectively using the same technique. And in this patient with L2-3 with a hip weakness, again was managed with very similar technique using a tubular microendoscopic discectomy. Yes, bleeding is a challenge and it has remained the commonest enemy for a tubular spine surgeon. Iatrogenic pars fractures can happen if you're not cautious in your resection of the facet, and that's why it's very important that you remain more towards the transverse process side rather than the on the side of the pars or medially. And if you're not meticulous enough to take care of all the fragments, you may leave behind fragments. But this problem doesn't come because it's like a direct decompression right in front of your eyes, and the fragments can actually be explode in the axilla up there, and migrated fragments can also be taken care of. We have been doing this for quite some time now, and I think we are extremely happy compared to the other approaches which have been a common thing in our practice earlier. But now for last 7 years, I have stopped doing anything else but tubular MED for all these far lateral disc herniations. So to summarize, it's far lateral disc is an enigma and is very commonly missed if you're not cautious enough and have a high index of suspicion, because the fragment lies away from the canal, not in the conventional place where you look for paracentral disc herniations. The principles and indications of surgical management remain the same. They are not different. Just because it's a far lateral doesn't mean you have to do surgery in all cases. Or when you're burnt out all the conservative means of treatment of these patients, surgery comes handy. And when surgery, of course, the options are plenty. But in my hands, I think microendoscopic tubular decompression works the best. Thank you, gentlemen. Over to you, Raymond.
Thank you. Thank you, Dr. Kundnani. So do we have any questions? That's an excellent talk. Any questions for tubular? I'm not sure if our UBE talk is here. So that would be interesting to hear about UBE. So if not, we'll skip to the next speaker then. So it's Worawat. Hi,
Hi.
Worawat. Hi. So you're going to talk about fusion, I believe, for
Yes, that's my job now.
lower foraminal disc herniation. So please proceed.
Right. Dr. Kundnani, can you please stop the share so that I can? Thank you. Hi, good afternoon, everyone. So this is my talk today about the extraforaminal disc herniation. As Dr. Kundnani already mentioned, fusion is the last option for this treatment because, as you can see, there's several options to treat this extraforaminal disc. But in some situation, you need some definitive treatment for that segment, which is fusion. This is my disclosure, which has nothing to do with this talk. So the question is, when would you think about the fusion? The only two ways that for the extraforaminal disc herniation, I think is only the instability sign, which is clinical and radiograph. Also, as Dr. Wu have already mentioned, if you have a problem with, especially in the difficult level like 5-1, the endoscopy could not be there at the exact point of the foramen, you may need to go posterior, and that you need to cut a lot of facet, which create the iatrogenic instability. Now you have to think about the fusion. Also is the recurrent disc herniation or the high risk of factor of recurrent. As you know, this is gonna be second or third operation, which is fusion. Why not fuse to prevent the recurrent, which is a high risk of the patient. So fusion has been described for the extraforaminal area for quite a while by Frank Philip and Benjamin Cumming in 2002, so more than 20 years. They call it the intertransverse lumbar interbody fusion, which has shown in the literature. They study in the cadaver dissection and have treated in 2 patients and reported in the Spine Journal. So basically, it's the same as Dr. Kundnani have mentioned. We go in between the lamina area, gently track the nerve root, and then go into in the extraforaminal zone. So it has been there for a long time before the endoscope has come. But there's still some problem, as I said. You can create the iatrogenic instabilities, which needs fusion. By this study, comparing to every technique that our speaker have already mentioned, fusion may be benefits in some situation, like if you need an interlaminar approach, partial facetectomy or complete facetectomy, which created iatrogenic instability. When is that going to happen? So the extraforaminal disc is at L5S1 due to the narrow of operative window and limited for the large TP, iliac crest, or the sacral areas. And also there's another situation like there's a herniation in several areas, not only the extraforaminal zone, but also the intra and extraforaminal zone, so that you have to decompress all the way and all along the area of the, especially the facet joint, so that you need to resect a lot of bone work and then create iatrogenic instability. That's the problem that we need to think about the fusion here. So, and also, even though Dr. Kundnani prefer the microscope or tubular microscope to treat the extraforaminal zone, this European Spine Journal just published last year in single study in single institute, showing that the tubular microdiscectomy shows quite amount of recurrent, even though that's slightly more than which Dr. Wu have mentioned in the extraforaminal disc herniation recurrent, like 5 to 10%. This study shows up to 12%. And also other study also mentions that it's up to 15% of the recurrent disc herniation, which need reoperation. Why? I'm sure that it's because of the some of the surgical techniques that you're not getting a good amount of this out, and also you cut a bit more of the parts, so that creates iatrogenic instability, which Dr. Kundnani has already mentions that you have to be really careful cutting the parts. So be careful using the tubular. It can leads up to 15% of the reoperation, not only the recurrent disc herniation, but reoperation. So when you think about the fusion and recurrent disc herniation, as you know, if there's some modic change, instability sign, and clinically, if the back pain is predominant, and also the dynamic symptoms or mechanical back pain, you think a lot about how to treat this back pain with the fusion. Several options, like I have mentioned, but comparing to the repeat discectomy and the fusion, our study quite a while ago in 2019 showed that not significant difference in the other clinical outcome. But as you know, if you design to do the re-discectomy, there'll be less blood loss, less hospital stays, and the less operative time. But obviously, there's a higher rate of the reoperation. So the risk factor in the patient side, if the patient have a very high risk factor like obesity, BMI more than 25, or the old age, or even the disc protrusion, which we see a lot in the extraforaminal zone, these are the risk factor of the recurrent. You have to be really careful choosing the patient. Several options has mentioned. There's several ways to treat the extraforaminal area. You can do the posterior like T-lift, P-lift, in the lateral will say for the E-lift, extraforaminal lumbar interbody diffusion, as mentioned before, or the lateral O-lift or neck lift. So this study have proposed microendoscopic assist extraforaminal lumbar interbody diffusion and showing very good results in 55 patients. And I also mentioned the comparing the benefit of each techniques. As you can see, the lateral O-lift and neck lift has a bit more of the minimally invasive way of the fusion rather than going to the back and have to cut a lot of bone work. But they have some limitation due to the 5-1 and some of the position change. By treating in the conventional way, MAS T-lift, fusion using the extraforaminal lumbar interbody diffusion have shown very good significant results. But be really careful with the complication because you are working underneath the dorsal root ganglion and the nerve. You have to be really careful while putting the cage in because there's some, temporarily, even though temporarily, but nerve injury can cause some significant pain after surgery. This is my video showing that when you think about the lateral, even the X-lift or O-lift, we can treat the extraforaminal area by, directly going across the disc and then taking out the disc into the contralateral side easily. And you can also treat the extraforaminal area in the approach side as well, because by gently traction a bit of the psoas muscle, as you can see, is still in the shadow of the navigation, but we can gently track it away from our surgical approach so that we can working on the extraforaminal zone, and then even though there's a significant osteophyte, you can clear it easily with the lateral approach. As you can see in the static view, so gently retraction of the psoas muscle, you can approach to the back and at the extraforaminal zone, which means that this is the kind of like a direct decompression with the lateral approach for the extraforaminal area. It can be the indirect decompression as well, as mentioned by Heinz' paper. They have shown only one patient that's 45 male left thigh pain But I believe not indirectly, because he did like a lateral approach from the right side, which means that he go from the right side and then go directly to the left side, and then removal of the extrafemoral disc herniation, and show a significant improvement of the pain. And one of the study, which is quite fancy, so they use the olive approach, but they want to clear the extraforaminal disc by using the endoscope, the lateral biportal endoscope, putting the scope in and then try to clear the disc. Even though you can see the directly sees the disc that you can remove in the extrafemoral area by the endoscope, they did a study and showing that comparing in 45 patients, 27 in using the biportal endoscopy, or versus the olive alone in 22 cases, it shows that the olive has significantly better pain relief after lower in the lower limb and buttocks. Why? I believe not because of the surgical technique itself, but as you can see, the operative time is significantly different. So by putting the endoscope, it means that you do the psoas traction for quite a while, more than an hour, comparing to the olive alone. So that can cause some of the buttocks and the leg pain. However, with the endoscopic, there's significant improvement of the spondylolisthesis reduction and the disc size. Why? Because you remove a lot of this and then you clear everything by the direct visualization of the endoscope, so that you get a very good radiographic outcome. But we be really careful with the psoas retraction time. So in my point of view, the MIS strategy for extrafemoral disc herniation now is that when you think about the fusion, start with if there's any instability or high risk of a recurrent or severe central cranial stenosis, that you need a really clear bony work for the decompression. If not, you can do discectomy alone, decompression, microendo, tubular, any ways that you can treat with the soft tissue. But if there's some factors that needs fusion, you can ask if there's any dynamic symptoms. If there's a dynamic symptom, you can do that indirect decompression using any kind of method. That's okay. But if the symptom is a problem by static symptom or that's recurrent disc herniation, you may need more of like a direct decompression. You can do a direct decompression at the extrafemoral area by using the MIS approach or the lateral olive approach, so that you can go directly to the extrafemoral zone. The problem will be 5-1. You can either use a posterior approach and also think about the anterior approach, the airlift, because you can clear out of this in several areas. So there's several options that can be treated extrafemoral disc herniation with the fusion, and think about what is you're familiar with, and then MIS techniques that's feasible for the direct visualization or direct decompression at the extrafemoral zone. Thank you.
Oh, thank you, Worawat, for the excellent summary on the fusion options for treatment of these tricky disc herniations. Do we have any questions for fusion? Okay, we have Dr. Aygun is actually online now, so he can talk about the UBE, which would be a very interesting talk. So, Dr. Aygun, can we have your presentation? Can we share your screen and see your presentation? He's online. I'm not sure if he's Dr. Aygun.
Hello?
Hello. She will present now. Hello.
Hello. Yes. Yes.
Yeah,
Thank you.
we are in the lab.
Oh,
Then the Miss Cheatham will present now instead of me. I'm
Okay.
waiting.
Thank you.
Okay, thank you. Thank you
Yes,
so
Chidam.
much.
Thank you.
Yeah.
Okay.
Hello. Hi, everyone.
Hello.
Hello.
I can hear you. Yes.
Yeah, thank you. It's so nice to be with you. Uh, I will share my presentation. Okay. Can you see? Can you see my presentation?
Yes.
Yes, we can see it. Yes. All good.
Okay, great.
Thank you. Can you proceed?
Uh-huh.
Thank you.
Okay. Hi, dear colleagues. I'm Dr. Çiğdem Mumcu from Turkey. Now I would like to present to you paraspinal UBE for extraforaminal disc herniation. As you know, far lateral disc herniation is not within the spinal canal, but outside the canal. It is less than 10% of all disc herniations, and intraforaminal and extraforaminal lesions are most equally common. And it is usually located at L3-4 or L4-5, even rarer at the L5-S1. Typically, the exiting nerve root is compressed and displaced, and it is also close to the dorsal root ganglion, so very painful. Conservative management is successful less than 10%, and surgery is usually required. When planning the surgical approach for foraminal and far lateral disc herniation, it is better to decide according to anatomical location of the disc. A foraminal region is between the medial and lateral borders of the pedicle. Extraforaminal region is outside the lateral border of the pedicle. In the foraminal region, we are talking about three zones. Normally, if we divided the foraminal region into three equal parts, first part, medial to the pedicle, is inner zone. Second part is middle zone, and third is outer zone. In other words, we can classify the inner zone is zone 1, middle zone is zone 2, outer zone is zone 3, and far lateral. So herniated disc may completely cover all three zones. It may be completely inside the foramen, or it may be completely far lateral. Far lateral discs are usually characterized by severe pain and loss of sensation. The pain is mostly burning. There is an exiting root involvement, and usually LASIK test is negative. So how should we approach that? Foraminal disc herniation should be approached according to their zone. All discs in zone 1 are easily removed from the inside. It is useful to make a distinction here. If the disc herniation is at level of the disc in the inner zone, we can proceed with a normal standard discectomy. If disc herniation is the inner zone but in the magna-obsidian zone, you can approach using contralateral UBE. For zone 2 disc, it depends on the situation. If the tail is close to the inside, it should be done from the inside. If it is close to the outside, it should be done from the outside. For zone 3 herniations, for large herniations filling all zone 1, 2, and 3, and far lateral herniations, it must be entered from the outside. L5-S1 far lateral discs are difficult to access. First paraspinal approach was described by Watkins in 1959. Wills et al. Modified it 1988. Paraspinal UB is similar to the Wills technique with endoscope. Paraspinal UBE has many advantages and overcomes the drawbacks of earlier open microendoscopic and uniportal endoscopic procedures, including easy access to extraforaminal lesions, independent movement of the working channel, minimal risk of facet instability, High quality imaging and special endoscopic instruments are not required. The basic surgical steps in paraspinal UBE include prone positioning, level marking, paracentral incision, creation of working space, making working and endoscopic portals and discectomy. General anesthesia is usually preferred. The patient is positioned in the prone semiflex posture. To prevent ISP, the patient's head should be raised by 10 degrees. The principles of paraspinal approach are the same as for the paramedian UBE. Two portals are created in the paravertebral area here, and two horizontal incisions are made in the imaginary line connecting the two transverse process, 1 to 2 centimeter from the lateral edge of the pedicle. Here, the target point of the triangulation is isthmus. The anterior corners of this triangulation are the superior and inferior transverse process. When creating the working space, we should feel the edge of this transverse process and isthmus by instrument. Our endpoint is Cumbin's triangle. Cumbin's triangle is a right triangle on the dorsolateral disc, and it is the safest way to enter the disc herniation. It is therefore of strategic importance in extraforaminal approaches. As you know, its boundaries are superior end plate of the inferior vertebral body, superior articular facet, and exiting nerve root. Theoretically, our target here is the area between two transverse process and lateral to the facet. We remove a little from the lateral part of the facet. Exiting root usually emerges close to the superior transverse. Disc is usually just below the inferior transverse process. Then we can easily find the disc. If there is no annular tear, if there is only an extruded disc, it is sufficient to remove the fragment. There is no need to perform a discectomy. However, if there is an annular tear, a discectomy must be performed. Now, let's look at a case example. This case, 40 years male presented to us with severe left leg pain and numbness for 1 month. He had motor weakness. Conservative treatment is failed. This case with both zone 3 foraminal and far lateral components on L3 to 4 level. This is post-operative images. You can see our tracing on CT. In this video, left side is cranial, right side is caudal. After clearing soft tissue by RF, lateral edge of isthmus and tip of SAP removed. Then now ligamentum flavum is removed. Look, we found the exiting nerve root here, and we put it in the center. Then here we found the disc herniation, and then did a discectomy. Then last check. And finish the surgery. What are the complications? A root injury, dural tear, hematoma, facet injury, instability, sometimes retroperitoneal fluid collection can be done, but it is very rare and mortal. L5-S1 paraspinal UBE can be easy in some cases and very difficult in others. One of the reasons for this is that in some patients the TP of L5 is very large, or there is partial sacralization, so the foramen may be completely closed. Therefore, it is absolutely necessary to see the AP X-ray before surgery. The most important detail here is this: while the distance between the superior and inferior transverse is wide at other levels, at L5-S1 it is both narrow and difficult to operate on because you have to work in a very deep place. It is necessary to transform this into a wide intertransverse space like the upper levels by taking it a little bit from the transverse and sacral ala during the operation. We can say a few tricks to this. First of all, we really need to see a coronal or AP radiograph. If you do that, you can see the relationship here very clearly. The window between L5 transverse process and sacral wing may be relatively wide in the left side picture, but very narrow the right side. The second most important trick is to identify where the space is narrowing. It could be facet hypertrophy, partial sacralization, sacral wing. You have to see that on the AP X-ray at L5-S1. Then we have to plan accordingly. And of course, the third trick is that we have to widen the narrow area in L5-S1 so that it looks like a normal area like the other levels. To summarize, surgical approach for far lateral disc herniations should be selected according to their zones. All zone 1 discs are easily removed from the inside. For zone 2 discs, it depends on the situation. If the tail is close to the inside, it should be done from the inside. If it is close to the outside, it should be done from the outside. For zone 3 herniations, for large herniations filling all zone 1, 2, and 3, and far lateral herniations, it must be entered from the outside. L5-S1 far lateral discs are difficult to access. Paravertebral UBE offers a safe, less risky, and minimally invasive approach to foraminal and far lateral disc herniation. Thank you so much for your listening. Thank you.
Thank you. So thank you for the excellent summary on UBE. Do we have any questions for UBE now? And any questions for any of the speakers? Okay. I've actually got one case to share. I've got can I share my screen? Share my screen. Okay, so let's share screen. This one. Okay, so there is one other option which we didn't talk about, which is to do a total disc replacement. So I've got one case here. This patient has had back pain for 13 years, and he's had recent deterioration in back pain with severe left leg pain and numbness. So this is his X-ray. and there's severe pain. So this is actually from a foraminal disc herniation at the L4-5. So the L5-S1 disc has collapsed, putting a lot of pressure on 4-5, and 4-5 has a triple disc herniation. So there's a foraminal component, there's an intracanal component, and if you look at that L4-5 disc, it's a bit of a mess. What would you do for this patient? Would you just decompress him? Would we fuse him? But if you fuse him, he's got a black disc above. Even the L2-3 disc is showing signs of degeneration. And if we do a fusion, and we're just pushing the problem elsewhere. So for him, because he's got more than one disc herniation. This is actually a recurrent disc herniation. It just happened. He had a intracanal disc herniation, and then it was complicated by a further foraminal disc herniation. So this is a very, very bad disc herniation. This disc is unstable. So just doing a decompression alone may not suffice. So in the end, I did an anterior approach for him, removed the entire disc and also removed the foraminal disc herniation. And he had a 2-level TDR like this. And the disc herniation's been removed from anterior. So we didn't talk about this, but this is an option for very bad foraminal disc herniations where the disc is unstable. So instead of a fusion option, there is always a TDR option. It's less invasive than a fusion, and we're preserving the motion. So he had a 2-level TDR. Yeah. The clips are from a previous surgery he had done for a hydroureter. So he had a hydro. Yeah. So that is an option as well. So let's stop the share here. So yeah, so lots of options available for these foraminal disc herniations. So do we have any other comments or questions from the speakers? I like doing TDRs, but anything? If not, I'm sorry for the delay today. I was confused because the chat actually has someone posted the APSS meeting on there, and I got confused by that because that's actually tomorrow at 1 o'clock. So I thought I was on tomorrow at 1 o'clock. So that's why I was late, because I saw 27th. I said I thought it was the 26th, and I saw that on the thing. So I thought it meant our talk, but someone actually put that into our talk. So I apologize for the delay in starting. So I'll see some of you at the, I think the next meeting should be scheduled in June. I'm not sure if there will be one. I'll speak with Arvind to see if we have another webinar in June, because our meeting's in July. So it may be that we postpone the June one. We haven't finalized anything for June yet. But if anyone wants any particular subject or any webinar, we can, because we're open. We haven't decided anything for June yet, so we can arrange something for June if anyone would like. Yes.
Raymond, I think there's a question in the chat box for all the faculty members.
Okay, let's see. Let's see if the chats. Here we go. Do you have any tricks for preventing the reherniation? Okay, so okay. Well, there are certain. I'll answer for the first one. So there's something called a barricade, which we use for. I'm not sure of the results. So it's basically an annular closure device. So it's like a little trapdoor that you put in front of a big hole. And certainly when we do our microdiscectomies, we often find that afterwards you remove the disc herniation, you're left with a big hole in the disc, and you can say to the patient, your disc is quite unstable. Be very careful. So the first thing we advise patients after any surgery that is just a microdiscectomy is you have to be very careful for the first 3 months. I don't know what the other people's advice is, but 3 months, because the microdiscectomy is sometimes it's a good surgery because what it does is it induces bleeding. And when we sometimes see reherniations in the same disc, it's not at the same location, it's on the other side. So it means that whatever you did before, that scarring, which you get from bleeding, probably sealed off the annulus. The annular defect was pretty sealed off. And sometimes when we go in, we can't actually find the previous annular defect. If you're going in again for reherniation, you try and find the old one. You can't actually find it. It's sealed off. So annular defects do heal because the outer part of the disc is vascular. So, and especially after surgery, there is some bleeding, and platelets can do their thing and generate scar tissue and seal off annular defects. So the first thing to preventing reherniation is after surgery, no lifting. You have to be very careful not to cause reherniation. So we often see that. We often see patients have a surgery and then they go and do something silly like bend forwards. So I tell them no bending, no lifting for 3 months after any decompression surgery. Do any of the other, any of the presenters have any other suggestions? And then there are annular closure devices. But if it reherniates, I usually tell them, first time we'll do a decompression. The second time you have to consider some kind of stabilization surgery because we don't want to go in there a third time. So often my advice would be first time round we can just decompress it, remove the hernia. But if it comes back, you should consider something to stabilize that segment, either a disc replacement preferably or a fusion if you don't do disc replacements.
I think many a times surgeons tend to just be very happy with doing fragmentectomy alone, and they don't explore in the disc. So I strongly recommend that one should explore in the disc. There might be a hidden subannular fragment lying there, which might remain innocuous for a while before coming back again, like a recurrent disc herniation. So intradiscal loose fragment, you don't want to really scrape out the disc, but surely do go in and remove with a non-tooth disc punches. That's what my practice is, that with a non-tooth disc punch, remove as much disc fragment is coming without really having to pull out or scrape out. And subannular nerve hook, because many of times the fragment might, apart from an external out of the annular sequestrated fragment, there might be a subannular fragment which might be just lying under the annulus and may just pop out if the patients are not careful enough in the first 6 to 8 weeks.
Yeah, we find that as well. So what I usually do for all my discectomies, microdiscectomy, foraminal discectomy, is we put a cannula inside the disc and then irrigate under high pressure. And if any loose fragments, they'll usually come out. And sometimes we flush out, think that sometimes the whole fragment dislodges. When you pressurize the disc, something comes out, and that's a loose fragment. So that's what I usually do. I irrigate it thoroughly, and hopefully we'll get something out. Some people will also, after their discectomy, inject the disc with some PRP to try and put some platelets inside there to help to seal it off. So that may be an extra trick to prevent reherniations and further disc degeneration. Any other questions? Okay. So we'll look forward to the next meeting. We'll discuss with Arvin, and if anyone wants any topic discussed, we'll try and get together some presenters and present the next topic. Thank you.
Thank you, Raymond. Thank you.
Thank you. Okay, have a good weekend, everyone. Thank you. Bye.
Thank you. Bye-bye.
Thank you.
Bye.
See you soon.
See you soon. Bye, Kim.
Bye-bye.
Bye, Dr. Kim. Pleasure seeing you again.
Yeah.
We put you together from the lab. Yeah, yeah. Thank you.